Yeah, this is a study from the lab, from our lab, presented by Benjamin, that will be presented at IMS by Dr. Benjamin Diamond. And the study is based on whole genome sequencing, that is a technology, an approach able to characterize the entire genomic profile of tumors. And in these settings, these are not myeloma samples, but these are samples collected from myeloma patients that develop a therapy-related tumors, mostly leukemia or myelodysplastic syndrome. This is a very important topic because with the improvement in overall survival for myeloma patients, we are now facing a lot of so-called long-term toxicity. So we are now good for at least more than half of the patients to induce a prolonged response. But what we don't want as a patient in sustained MRD negativity that he's or she's doing a perfect life, absolutely normal, all of a sudden develop one of these secondary tumors. Because most of the time, these tumors, in particular the myeloid tumors, are very aggressive, and often it's hard to be cured. And in many cases, unfortunately, the patient dies for this. So it's a complication that is a life-threatening complication. So we need to do as much as we can to prevent this and to understand which are the genomic mechanisms or why we have this increased risk, which is estimated around 2-3% of the myeloma patients that are treated with the autologous cell transplantation. So this is the first whole genome characterization of this entity. We compare our data with also genomes from other therapy-related tumors, from platinum, for example, treated patients like in ovarian cancer or breast cancer, and other tumors that have not been treated with any mutagenic agent. So the study is very dense and complicated, but the overall idea is that for multiple myeloma patients, all patients, as previously described, that develop this condition have a precursor clone in their blood before, many years before, called clonal hematopoiesis, or CH. And but the idea that many people have is that this chemotherapy that we give provide an insult on the clonal hematopoiesis, and this is making the clone more complex. Or another idea is that it's just a matter of selection. The chemotherapy select the most aggressive or the fittest clone to proliferate in the future and take the dominance. So in this case, what we found is that there are two different model or pathogenetic routes between avenue from clonal hematopoiesis to therapy-related tumor in post-autologous transplant patients. So one is where a clonal hematopoiesis with p53 mutations is able to survive high-dose melphalan myeloablative conditioning regimen. And that's where we see the melphalan mutational signatures, which is a direct damage that our lab reported many times now in more than, I think it's like 3-4 papers, plus other people already found it in other disease and also multiple myeloma. So every time that melphalan is used, introduce hundreds of mutations. And so we know that the cells was exposed to melphalan, and often this mutation also increase the genomic complexity of these cells. And so if you have TP53, you are able to survive this conditioning regimen. And so we see all this complexity and we see all this melphalan mutation. If you don't, that's something we don't see. So if you don't have TP53, of this clonal hematopoiesis doesn't have TP53, can be reinfused through the leukapheresis. So the transplant is based on the fact that you collect the CD34 stem cells and then you reinfuse back after the chemotherapy. But if you have the clonal hematopoiesis, you will reinfuse also the clonal hematopoiesis. And that will drive a post-transplant proliferation of a clonal hematopoiesis that have never been exposed to chemotherapy. And so we don't see the melphalan damage on those cells. So it's kind of like black and white. And of course, he has a lot of implication because, of course, TP53 mutated CH clone have a certain risk and can survive myeloablative conditioning with melphalan. But the fact that you can develop therapy myeloid tumors, very aggressive, even without this clonal hematopoiesis be exposed to melphalan, because if it's skipped through the leukapheresis, there is no contact between the cells and the melphalan. That means that is not the damage on the chemotherapy on the pre-tumor cells, but probably there is something else, like more space in the marrow because most of the stem cells probably are dead and there is a population of the marrow, or prolonged immune suppression. These patients after transplant have a prolonged immune suppression that can last even more, like sometimes more than 1 year. So all these players are still unknown, but the fact that we saw this data and the proportion is 70% of the patients don't have anything, which means they are infused, suggests that their infusion and the immune dysregulation introduced by transplant are something important that we need to investigate in the future.